Hello class. I'm just going to provide you an online lecture of the material and content that we normally would have went over if we would have had class on Wednesday. So I want to begin by showing you that on the screen is Appendix 3, and what this is a abbreviated list of the national patient safety goals that I went over with you on Monday in regards to all the various situations that Joint Commission looked at in regards to patient safety. And this is kind of the abbreviated form that I would like you to be able to review. It is in your syllabus under one of your appendices in Appendix 3, and it starts off talking about identifying patients correctly by the way that we use two patient identifiers. It talks about the correct patient who gets correct blood type when they get a blood transfusion. Again, the importance of communication, especially when labs are drawn and there are very, very serious abnormal lab results back. Those need to be communicated to the nurse immediately, and then there's the proper documentation of that communication so that the nurse can hopefully analyze how serious that abnormal lab work is and immediately call her physician to report that to the physician to hopefully provide a very quick intervention to help the patient. Again, about medication safety, alarm safety, and again how we can prevent infection in the hospital once our patients have been admitted. And again, that always starts with the basic way in which we do prevent infections for our patients is to do proper hand washing. Again, identifying patients who do have safety risk, especially when we kind of do that admission assessment on our patients and really assess both the physical and the mental aspects of our patient, finding out which patients are most likely to commit suicide. And then again, all the problems that have been occurring in surgery to prevent those mistakes in surgery, making sure that the correct surgery is done on the correct patient and at the correct place on the patient's body, to mark that correct place on the patient's body where the surgery is to be done, and to pause before the surgery to make sure that a mistake is not being made. So those again are what we call the patient safety goals, the 2018 National Patient Safety Goals. And as you continue to be involved in the profession of nursing, you may see down the road that we may add more to this list depending on the circumstances that occur that may put our patients in harm's way as we continue to take care of them. So be on the alert, because maybe in another year or two we may be adding to this list. So please be sure that you go over the PowerPoint, which is provided to you in Canvas under week 1. The PowerPoint gives you a little bit more detail about these National Patient Safety Goals, but this is also a nice way to just kind of review exactly what are the items listed on the National Patient Safety Goals in kind of more of an abbreviated form. So be sure you're aware of this, okay, especially before the test. And now what I'd like to do is go over the activity that we would have done in class regarding the National Patient Safety Goals. This is in your syllabus, listed as Appendix 4. We're going to talk about 2 case studies. And the first one, case study Part A, is about a patient, Carrie Brandt, has been admitted to the hospital complaining of severe back pain, vomiting and nausea, had a urinalysis done and an MRI, and the patient has been diagnosed with renal calculi, or what we know in lay terms as kidney stones. The physician orders administration of 2 milligrams of morphine, sulfate IV, and 2 nurses, Peter Martin and Danielle Sanchez, are present when the physician issued that verbal order. So Danielle, who is the patient's nurse, withdraws a syringe containing 4 milligrams per 2 milliliters from the automated medication dispensing system and walks to the patient's room. When preparing to withdraw the medication for a patient assigned to his care, Peter glances at the dispensing receipt that was printed for the previous transaction, and in particular, Peter notices that Danielle appears to have obtained twice the dosage of medication ordered for the patient. So Peter follows Danielle to ask about the discrepancy. By the time Peter arrives at the patient's room, Danielle has administered the morphine to Miss Brandt. So when Peter privately inquires as to the amount of medication given, Danielle replies, "I gave all of it." She gave the whole 2 milliliters, which means she gave double the amount of the ordered drug. Instead of giving 2 milligrams of morphine, this nurse administered the whole 4 milligrams. Peter points out that administration of the 2 milliliter dose means the patient actually received morphine 4 milligrams, as opposed to the ordered dose of 2 milligrams. Danielle replies that the additional 2 milligrams of morphine likely will not harm Miss Brandt and that she will monitor her closely. Danielle then asks Peter not to issue an incident report because she is afraid she will be reprimanded and possibly lose her job as a result of her error. So all I ask you to do is just to kind of think about this and think about what you would do if you were in these circumstances. And this could very well be you after you graduate, or maybe down the road while you're still in our nursing program, you may encounter some unethical behavior that you really see could put your patients in harm's way. So what are you going to do about it? And this is why I can't emphasize more that you are important, and don't ever think, well, just because you're a student nurse, that your voice will not be heard. It absolutely will. So if there are issues that you feel really does put our patients in harm's way, you need to report it. And as a student, I probably would go to your clinical instructor if this is happening in the clinical area, and definitely let her know the situation, and then I'm sure she will make the proper judgment as to who she should notify next, person next in line, to be aware of the harm that may come to a patient. But in this certain situation, I think question 1 is a great question. How do you believe this situation should be handled? Should Danielle report the error? And I'd like you to think about your answer. We know that there has been, first of all, a very serious med error made. And the reason I say that is because we're talking about a very potent pain medication, an opiate, namely morphine sulfate. And I know you haven't had a lot of pharmacology yet, but morphine is used for very severe pain. And one of the very serious adverse reactions to morphine is it could cause severe respiratory depression. And we do not know anything about this patient. We don't know how old she is. We don't know the size of the patient. But the fact is, we do know that morphine can cause respiratory depression. And that could be a very life-threatening situation. So right off the bat, we do have a patient who could be in very serious jeopardy of her health. Could be very life-threatening. And being that this is the first time that we are administering this medication, we don't really know how that patient is going to respond to the medication. So that's another reason why we would definitely not want to give that whole 4 milligrams for 2 reasons. Obviously, it wasn't ordered that way. And second of all, we always like to start in smaller doses to see how the patient responds to that medication. So that is definitely a very a serious concern of mine, and I'm sure is from you as well. But what does Peter do about the situation? You know, I think maybe after the fact, obviously to make sure that our patient is safe and doing okay after the administration of this medication. I think that's our first concern right now, is to assess the patient immediately after giving this medication, because seeing that it was given through the IV route, we're going to see results occur very quickly. So I'd want to be sure patient is breathing okay, perfusing okay, blood pressure is good, and then obviously assessing to what level of pain the patient has after this 4 milligrams of morphine was administered. So saying that the patient is doing okay, now we have to think about, where does Peter stand with this? And I think personally he would go to this nurse, Danielle, and say, you did something seriously wrong and you really need to own up to it. And I would give her that opportunity to be able to kind of turn herself in and confess to the situation, probably to either the supervisor that night or to the nurse manager. And then, of course, definitely an incident report needs to be made. But please understand, too, with the way that we have our medications being dispensed, usually it is in a Pyxis, which basically is a computer. There will be a record of this, that the whole 4 milligrams was administered, because in this case, if she had only given the 2 milligrams, which was the order, that other 2 milligrams would had to have been wasted. So with the Pyxis, usually to waste a narcotic, you need the witness and signature of another registered nurse. And if that is not documented within the Pyxis or the unit that provides us our patient's medications, then that history in that computer would not be there. So I'm sure the next question would be from the pharmacist or the pharmacy aides who then go over these medications once they're administered. Where is the documentation that the waste had occurred from that medication? So that's another one of our concerns. So if Danielle would not be honest and go to the nurse manager, then it would be Peter's responsibility to go to the next person in the chain of command and report, unfortunately, this very, very serious error. And I think what bothered me most about the situation was the fact that this nurse, Danielle, really never felt much remorse. And she didn't seem concerned that she overdosed not really overdosed, but gave twice the amount of medication to the patient. And another concern I had as I read the scenario was, if she's doing this, which was witnessed by Peter, is she doing things, other things behind everyone else's back that may put our patients in jeopardy? So there are ethical considerations, as noted in question 2, that involved in reporting versus not reporting this error. The possible ethical problems that arise from not reporting the error include the endangerment of the patient, the reinforcement of unsafe nurse behavior, and a lack of error reporting transparency, which means, we do make mistakes and we have to own up to them and we have to be transparent about them. And in this case, this nurse does not want to report it because she does not want to have an incident report made, besides the fear that she may be reprimanded and possibly lose her job. And that was another concern. Has she been making these types of error in the past, that maybe the nurse manager told her that if you make one more error, you will be fired or put on probation? So these are concerns that I have regarding this error. But the point is, she doesn't seem upset that she made it, and all she wants Peter to do is to pretty much cover up the situation, or cover up the error. There are no ethical problems in reporting the error because hospital staff will take the steps necessary to correct the error and provide education to the nurse. So again, here we have a problem that really does endanger our patient. It's a medication error. It puts our patient in harm's way, and it's a safety issue. So I want you to think about this, because I have been involved in these kinds of situations, and you possibly may also be involved in a situation like this. And I think too, when you have a nurse that is aware that this type of error has been made, then if that nurse does not come forward, maybe because they don't want to look like a tattletale or a squealer, and wants to be liked, I feel that that nurse is in just as much at fault as the nurse who actually, committed the error. So you have to look at it in that regards, because what are we there for? We are there to protect our patients, to provide them the best care possible, and to really keep them safe. And they trust us enough to do that, and we have to continue providing safety to the patient. And think about it. If this was your family member, your wife, your husband, your child, your sister, your brother, would you be happy about it? Of course you wouldn't. So think about it this way. We take care of our patients the way we as nurses would want our families and friends to be taken care of. So just something to think about. All right, let's go on to case study part B, okay? And this is an example of quite the opposite, where we have Michael Layer, who's age 28, has been admitted to the hospital due to a cold that developed into severe bronchitis, and Juliet Wright, Mr. Layer's nurse, enters his room and introduces herself. She then washes her hands thoroughly and puts a pair of gloves on before obtaining Mr. Layer's vital signs and performing a client assessment. Throughout the process, Juliet explains each of her actions to Mr. Layer. Following the assessment, Mr. Layer inquires as to the plan of care, explaining that his physician has not yet informed him as to how his bronchitis will be treated. He also believes he overheard one of the nurses mentioning that he may need a procedure to remove fluid from his lungs. But it has not been discussed with him, and he is opposed to the procedure. So the patient is very worried and would like some answers. Juliet reassures Mr. Layer that she will seek answers on his behalf and thanks him for sharing his concerns with her. So next, Juliet pages the client's physician, who arrives on the unit from another area of the hospital. The physician explains to Juliet that he plans to administer a course of antibiotics to Mr. Layer and has no intention of performing any invasive procedures. In addition, the physician thanks her for sharing the patient's concerns and notes that he will speak with the patient as well. Juliet and the physician discuss the antibiotics that will be prescribed as well as the current plan of care for Mr. Layer. After speaking with the physician, Juliet returns to Mr. Layer's room and discusses the current treatment plan with him and the types of antibiotics that will be administered. She also explains what actions Mr. Layer can take to help improve his respiratory function and prevent complications, including frequent repositioning and coughing and deep breathing exercises. As Juliet finishes conversing with Mr. Layer, the physician arrives to speak with him. So now we have a whole totally different type of situation occurring. And it's so nice to see nurses out there doing wonderful things with their patients, okay? So let's look at this first question. Okay, what CUSIN competencies does Juliet exemplify in her discussion with the physician and the client? So think about it. So now you have to go back to Nursing 100 and think about what those CUSIN competencies were. And I think the one that really sticks out with me is the fact that this is very, very patient-centered. Her focus is entirely on this patient, and she just does everything right at the bedside. She demonstrates knowledge of patient-centered care, exhibits comprehension of pain and suffering as well as the physiological modes of pain and comfort, and she determines the extent to which patient participation can affect safety, quality, and cost. And she determines methods of patient and family empowerment and elaborates on the precepts of effective communication. She involves the patient and families as partners to benefit health, safety, and self-care. And she does evaluate communication skills through patient interaction, and she really does play an active role in conflict resolution and compromise regarding patient care. She disseminates details of past and future steps of care at each stage of treatment, and she respects the patient's experience and expertise and acknowledges the patient's desire regarding his involvement level in his care. So, as you can see, another thing that I really kind of felt as I read the scenario is that she really gave her full attention to this patient. She may have been extremely busy that day, but as you can see, she really began the whole process of meeting this patient in such a professional way. She introduced herself. She then used safety precautions, great hygiene by immediately washing her hands. And then before she examined the patient, knowing that he was coughing and had bronchitis, she put on a pair of gloves. She did vital signs, and she did perform that patient assessment on him. And as she did this, what did this scenario say? It said that she did explain each of her actions to the patient, so he was totally aware of what she was doing and why she was doing it. And he had heard possibly that the physician was going to do this invasive procedure, which really seemed to cause him a lot of stress. And he kind of didn't have any idea if this was a true thing, so he did verbalize this to his nurse, Juliet. And so I love the fact that she listened to him. What are your concerns? You know, that she was probably asking in her head. And she could tell he was very worried about this. And the nice thing, she gave him a lot of emotional support. She reassured him that she would find out the answers. And she really did thank the patient for sharing his concerns. So she really respected what the patient had to say. So immediately, as long as she knew that her other patients were well cared for, she went about trying to find out the answers to this patient's questions. And she called the doctor immediately, and he came down from another unit, and this is when she began to verbalize with the physician what that patient's concerns were. Okay? And I really like the way the physician acted with Juliet. He very much appreciated the fact that she shared these patient concerns, and he told her that he would definitely speak with the patient. So after she talked with the physician, she went back immediately to help relieve a lot of this anxiety and told Mr. Layer what his treatment plan would be. That all we're going to do and all the physician is going to do for now is just order antibiotics. And then she's talked about the many nursing interventions that she was going to provide the patient in regards to helping him get better. Frequent positioning, encouraging coughing and deep breathing. We didn't want this bronchitis to get worse and maybe turn into a type of pneumonia. And so she just let him understand exactly, what was going to happen with him. And I'm sure after she got to talk with him, then all that information that the nurse provided the patient, the physician again reinforced exactly what Juliet, the nurse, said to the patient. So again, we see that Juliet did focus on the care, meeting the physiological as well as the emotional needs of the patient, making it very patient-centered. Really looking at the way in which she communicated to the patient that promoted safety. It was extremely well done, extremely well done. So I want you to kind of think about this situation, and maybe it gives you insight as to ways in which we can really demonstrate those cues and competencies. And again, it really is about providing patient-centered care, and again making sure that our patients are safe, and that we are meeting the needs of our patient not only physically but also mentally. As you can see from this Appendix 4, there is an additional case study. I'm not going to go over that, but I really want you to read that, Part C, about Margie Blank. Now this is somebody who we really get a little bit more information about the patient, and that she's 72. So again, it involves something to do with patient safety. I think this patient is a potential for a fall risk. So please read over that and think about how you would answer some of these questions so you can begin that critical thinking and critical decision. Think about it. Are you a nurse that has a situation like this with one of your patients? So read these over again and think about if there's any other additional information that you would like to add in regards to answering these questions after you read the particular scenario. And after reading this third case study, I want you to also think about some of the risk factors that may affect patient safety, in particular to falls prevention. So what can we do as nurses to prevent this unfortunate situation from occurring? So those are things that I want you also to think about. Now we're going to move on to our day 2 concept of leadership. And what I'm going to provide to you now is a short video about the nursing process, okay? It's about 10 minutes in length, so I want you to watch that. And then I'm going to reiterate the information by going over the PowerPoint slide with you on the nursing process. And then we'll talk about the nursing process, and then we'll go over some practice questions, okay? So I hope you enjoy the movie.
This lecture is a quick review of the nursing process, an integral tool used every day in patient care. The nursing process is a framework that enables nurses to create care plans and to look at what has been done, what should continue to be done, and what needs to be changed to assist patients to a state of well-being. The nursing process is usually described as having these steps: assessment, nursing diagnosis, planning. Some schools include outcome identification as a separate step after the planning phase, implementation or nursing interventions, and evaluation. You all are CPR certified and therefore have been instructed in the use of an automated external defibrillator, or AED. Since this material is familiar to you, we will look at the nursing process in terms of deciding to use an AED. What is the first thing you would do if you are walking a patient down the hall and the patient falls to the ground? Right, assess the patient. What would you assess for? What do AED guidelines say to assess? Let's check this video to see if we are doing it right. You assess the patient to see if he is okay. Based on your assessment, he is not. You check circulation first. You find the patient has no pulse.
Code blue!
You quickly think which nursing diagnosis would apply to this patient. The North American Nursing Diagnosis Association, or NANDA International, has a long list of choices, but the logical NANDA diagnosis for a patient with no pulse would be decreased cardiac output. Now you will move to the third step of the nursing process, planning. The best way to remember planning is to substitute the word goals or outcomes. What is the goal for this patient? The patient has no pulse. So the goal is: the patient will have increased cardiac output as evidenced by a strong pulse after emergency intervention. The next step of the nursing process is implementation, also called nursing interventions or nursing actions. Interventions are all the things the nurse does, arranges for, delegates, and so on to reach the goal. Watch the video and list all of the interventions that healthcare team members do to help the patient reach this goal. The patient will have a strong pulse after emergency intervention. You may have to watch the video several times to identify all of them.
If a cardiopulmonary arrest is confirmed, turn the automatic external defibrillator power on and place the adhesive defibrillator pads on the client's bare chest. One pad goes below the left breast, and the second pad goes just below the client's right collarbone on the ribs. The machine will alert the user to pad connection problems and suggest a remedy. The operator's voice and the client's ECG will be recorded on a removable digital data card inside the battery compartment. The recording begins when the power is turned on and continues for a maximum of 30 minutes. The automatic external defibrillator will instruct you to deliver a shock in 4 ways. 1. A voice prompt to deliver a shock. 2. A steady tone. 3. The shock button flashing. 4. A screen prompt to press the shock button. Say, "All stand clear." No person should be touching the client or the surface they are lying on. The client cannot be lying in liquid. Allow the automatic external defibrillator to analyze the heart rhythm. If another shock is advised, the automatic external defibrillator charges to prepare for shock delivery. Check the monitor to verify that a rhythm is either sustained ventricular tachycardia or ventricular fibrillation, and that the client does not have a pulse. Clear the client and press the shock button. Again, allow the automatic external defibrillator to analyze the heart rhythm. This client is now in sinus rhythm. Assess the client's pulse, blood pressure, and breathing while maintaining the airway.
Here is a list of the interventions you would perform for this patient with decreased cardiac output. If this were not an emergency and you were writing a care plan, you would list all of these interventions for the patient to ensure continuity of care. The final step of the nursing process is evaluation. During the evaluation step, you look at or evaluate all the previous steps of the nursing process. Assess the patient again. Is data the same, or is there more or different information to consider? Look at the nursing diagnosis. Does it still apply to the patient's condition? Review the plan, goals, and outcomes. Have they been met or not met? Determine whether to continue the care plan as is or to make changes. Determine which interventions worked and which did not. Consider whether the patient's condition has changed, whether the care plan should change, or whether interventions should be added or omitted. Evaluation is also known as reassessment, illustrating how the nursing process is continuous and interactive. It may lead to new findings and further nursing diagnoses. In fact, in most clinical situations, several nursing diagnoses exist, and they must be handled in priority order. In this case, since the patient is unconscious, we can continue to apply the nursing process like this. Assessment. Patient is unresponsive and unconscious. Nursing diagnosis. Altered tissue perfusion, cerebral. Plan, goal, or outcome. The patient will have increased cerebral tissue perfusion as evidenced by a return to consciousness. Interventions. Since we already know that the client has decreased cardiac output and the heart is not beating, we can judge that the brain is being starved of blood. Compressions must be provided to move blood to the brain. Evaluation. After a cycle of compressions, reassess the patient to see whether consciousness has returned. Let's sum up the steps of the nursing process one more time. Assess a patient to determine if there are any problems. Based on those problems, select appropriate nursing diagnoses. From there, make a plan, also known as goals or outcomes, for each diagnosis. List all the actions needed to implement each goal. Perform the interventions. Evaluate the patient. When reassessing, see if the nursing diagnoses still apply. Judge whether the plan and interventions are meeting the goals. Change the nursing care plan as the patient's needs change. The nursing process is a continuous and ongoing method of addressing patient problems and assisting patients to wellness. The nursing process never stops as long as a patient is receiving nursing care.
Alright, I hope you enjoyed that video from Pearson on the nursing process. I will upload that to Canvas if you would like to review that again. And as you can see on the screen, I have a PowerPoint regarding the nursing process and how nurses provide nursing care. Just for a little background in regards to the nursing process, it really has been around for a long time. It gained legitimacy in 1973. That's a long time ago, and it's included in the ANA, the Standards of Nursing Practice. And as you can see with the steps, as explained in the video, they very much overlap. And the thing that I like about the nursing process is it is very patient-centered, very client-focused. So in the assessment process, we do collect data and determine patient preferences and daily routines, and really helping to meet the personal needs to incorporate these in a plan of care. It really is an adaptation of problem solving. We as nurses begin to make decisions, so we really do become good decision makers involved in every phase of this nursing process. And it also involves very much of our interpersonal and collaborative type of communication in regards to providing all the information in each of the steps of the nursing process. Now, what I really want to make sure that you understand is when we talk about a nursing diagnosis, we are nurses. We don't diagnose, but we're not talking about the same thing in regards to a nursing diagnosis. What is a nursing diagnosis, and what is the difference between that and a medical diagnosis? Think about it. A nursing diagnosis is a statement of nursing judgment, and it refers to a condition that nurses, by virtue of their education, you're a very educated professional, and you have the experience and the expertise and are licensed to treat that patient. You describe the human response or the psychological, social, cultural, and spiritual responses to an illness or a health condition. Whereas with a medical diagnosis, that is made by a licensed provider, a physician. Such as, as I said, a physician, an advanced practice nurse, or even a physician's assistant. They refer to the disease process, more of a specific pathophysiological response, okay? And another difference between the two is the medical diagnosis remains the same for as long as the disease process is present, but nursing diagnoses can change as the patient responds to that change. So when we provide those interventions in the implementation phase, and we might make that particular problem or solve that particular problem with the patient. So now their nursing diagnosis is going to change. Hopefully that makes sense. And there are various types of nursing diagnosis. There's an actual one where it's a patient problem that is present at the time of the nursing assessment. Then there's a risk nursing diagnosis, and sometimes we even see wellness diagnoses. So I just wanted to make sure that you understood the difference between nursing diagnosis versus medical diagnosis, okay? So let's go over this PowerPoint, and then you can, ask me any questions this weekend or even bring them up in class on Monday, all right? Assessment. You learned this in Nursing 100. Okay, that's what our whole focus of Nursing 100 was about how to properly assess our patients. You gather information about a patient's psychological, physiological, sociological, and spiritual status. It really is that patient interview, okay, where we include patient, family history, observation, and a physical exam. And with diagnosis, as I explained to you just a few minutes ago, it is about making a judgment. It's a nursing judgment. It's a potential or actual health problem. And many of our patients nowadays who have such high acuities may have more than one nursing diagnosis, okay? We might find a patient who has multiple diagnoses. So what is the patient having a problem with? Is it sleep? Is it nutrition? Is it pain? Is it comfort? Is it mobility? Those kinds of things. Is it perfusion? Is it oxygenation? So next step is to plan or goal set, because we want to determine what is it we want to achieve with this patient, okay? What is it we want to see happen? So by discharge or by, within the next 24 hours, we would like the patient to be, pain-free or whatever. And remember, this goes back to when you do concept maps. The goals are to be determined by the acronym SMART, S standing for specific, M standing for measurable, A standing for attainable, R standing for realistic, and T standing for timeable. So this is what this refers to: measurable, mutually set, time frame, and realistic. So the implementation process is really prioritizing patient needs, and it should be individualized. So you may have 2 or 3 patients with the same diagnoses, but you may not provide the same interventions because everyone manifests the disease process differently. So it may include different things like care, monitoring, patient education, referrals, things like that. Maybe one person has a total hip, maybe one person is really having immobility issues where the other person is having more pain. So obviously those interventions are going to be very different for each of those patients, even though they had maybe the same surgical procedure. So then as we provide those interventions, then we want to look to see how they're working. Did the patient reach his goal? By discharge, was the patient pain-free, or was the patient able to walk from this distance down the hallway without having their pulse ox drop? So if those interventions aren't working, then we have to provide things that will. So this is why it is a continuous process as long as your patients are receiving patient care and nursing care. So what I want to say is, if you listen closely to this PowerPoint, I want you to hopefully see what this resembles. This is what you were doing when you were developing concept maps. You were going through the nursing process, okay? And when you're done listening to this, I want you to get out one of the blank forms of a concept map and think about what information goes in each circle, okay? Remember how we first started off with putting in that data, subjective and objective data, and then we wanted to see what the problem was, why it was happening, and what kind of interventions are we going to have, and what was the expected outcome. So that's basically the nursing process that you guys were doing in Nursing 100, okay? So I want you to hopefully see that correlation between the two, okay? So here's just an example of how we do the nursing process through, a realistic situation, a real life situation. And I want you to understand too is as we become nurses and we gain more experience, we really do go through this nursing process, but we don't stop and say, okay, I'm doing assessment. Okay, now I'm doing nursing, I'm making a nursing diagnosis. We kind of do this automatically in our heads as we gain more experience and as the longer we're professional nurses. So here's an example where John visits his general physician on Monday because he was feeling sick over the weekend. When he is called back from the waiting room, the nurse on staff takes his temperature and his heart rate and his blood pressure. She then asks John a series of questions about how he's been feeling, and so the nurse notes his responses when he says he's been having difficulty breathing and he's been feeling very tired. She also sees on John's medical history that he has had previous problems with his cholesterol and his blood pressure, and so she decides to take a specimen of blood to kind of check some labs for him, okay? So she looks over John's symptoms and she notes that his heart rate is higher than average and his blood pressure is elevated. And I like this about her because she took those vital signs and she looked at those numbers and she really thought about them. She analyzed them correctly and she realized that his heart rate is higher than normal and that his blood pressure was higher than normal. So she also considers that he's experiencing fatigue and shortness of breath before when his cholesterol levels were very high. So the nurse determines that John is experiencing hyperlipidemia, which just is a fancy term for saying that he has high levels of fat within his blood. So John's blood tests confirm this hypothesis. So the nurse is also concerned that John is at risk for heart disease. See how she correlated that problem? You know, obviously high cholesterol levels is a risk factor for developing cardiovascular or coronary artery disease. So then he returns on Tuesday for a follow-up visit. So the nurse sits down with him in a closed room and explains his cholesterol levels and his high blood pressure. She suggests that John be put on a medication to help lower these numbers and recommends he exercise at least twice a week. The nurse also tells John he should stay away from salty foods and eat less red meat. So John agrees with the nurse, and they set up a follow-up appointment 2 weeks later. Do you see now she is providing the implementation, the interventions. She knows what the problem is, and now she wants to provide him ways in which we can set the goal to hopefully reduce his blood pressure, his heart rate, help his breathing, and also get his cholesterol levels down. So the nurse reminds John to call if there are any changes in his condition or if he starts to feel worse. So John is prescribed the medication and he takes it as recommended. So now he's following through. He's implementing the interventions that the nurse, it's probably the nurse practitioner, suggested. So 1 week later, he has a day where he feels especially sick and he calls the doctor's office. The nurse explains that the medication could cause nausea as a side effect, and she advises John to drink ginger ale and avoid any foods that generally upset his stomach. So John continues taking the medication and goes to the gym 4 times during the 2-week period. So once the 2 weeks has passed, he returns to the doctor's office for his follow-up appointment. So now we're going to evaluate how did these interventions work. So when John returns, the nurse asks him a series of questions about how he's been feeling, and John replies that he's been having an easier time breathing and feels significantly less tired since exercising and taking the medication. So now she really can see that these worked and patient condition improved. So she congratulates the patient, really gives him some good positive feedback, and she then advises him to remain on the medication for 1 more month and to continue his exercise. So that's pretty much a good example of how this nurse, probably nurse practitioner, followed through with the nursing process. Okay, and had not John improved so well, then that's when she or the physician may have ordered new interventions and hopefully had the patient then implement those to see if we could reach those goals that we set for the patient. All right, class, here's just a little exercise about reviewing what you learned from the nursing process video as well as the PowerPoint, okay, and hopefully from the reading that you did. So let's go over these questions together. Question 1, by the second post-op day, a patient has not achieved satisfactory pain relief. Based on this evaluation, what should the nurse do next according to the nursing process? So think about that, and I'll give you a couple minutes to determine what the correct answer is. Hopefully you all said A, and that is the correct answer. Reassess the patient to determine the reason for unsatisfactory pain relief. And there is the rationale that's provided for you. Okay? Question 2, a nursing instructor is reviewing the steps of the nursing process with students. The students identified which of the following is objective data. Remember, you have to go back to Nursing 100. What's the difference between objective versus subjective? So this is one of your favorites, the select all that apply. So I'll give you a minute to think about this answer. The answer is A, D, E, and F. Objective data are those that nurses measure and observe. Question 3. A nursing instructor is reviewing which actions a nurse can initiate without a medical provider's prescription. with a group of nursing students. The students should identify which of the following as nurse initiated. Select all that apply. I'll give you a couple seconds on this one as well. The answer is C, D, and E. All of the above may be used without a medical provider's order. Number 4, during evaluation, the nurse must gather information about the patient to... So what happens during this phase of evaluation? And the answer is A. Identify whether the patient outcomes have been met. Evaluation involves gathering information about the patient to determine whether patient outcomes have been met. And the last question, a nursing student is reporting the care given to a patient. He or she states the patient said his leg pain was back, so I checked his medical record, and he received pain medication 6 hours ago. The order reads every 4 hours, PRN for pain, so I decided he needed it. I administered the medication and checked with him 40 minutes later. He stated that the pain is going away. Which step of the nursing process did the student leave out? And what I like to ask you as you read this scenario is, did the student nurse make a med error? So think about that. And the answer is no. But there is one important part of the nursing process that the student nurse left out. So think about what that is. And the answer is assessment. The student nurse should have used the assessment step of the nursing process by asking the patient to evaluate the severity of his pain on a 0 to 10 scale. And he should have also asked about the characteristics of the pain and assessed for any changes that may have contributed to the worsening of the pain. Remember, we learned all those in Nursing 100, Old Cart, things like that, that would really give a lot more information to the nurse as to why that pain has reoccurred. I mean, no med error was made, but you know what? The student just went ahead and said, yeah, it was time to give the medication, and just went and gave the medication without really looking at why the patient was having pain. Sometimes we don't always have to intervene with pharmacological interventions. We can maybe turn the patient. Maybe the patient is stressed. Maybe something that we can do to help alleviate the pain other than pain medication. So I just wanted you to be aware of that. All right. Hopefully these helped you out. I will definitely upload these into Canvas so you can refer back to them. You'll see these very same type of questions on your first test. All right, class, we're going to continue with our concept of leadership, and our exemplar will be delegation. And it's very important that you understand the 5 rights of delegation: task, circumstance, person, directions, and supervision. I've got a PowerPoint regarding delegation, and I will be honest with you, this is a very hard job for some nurses to do. I had a really hard time with delegation. I always felt like I was bothering someone, or I didn't want to feel like I was imposing on someone, or I didn't want to feel like I was dumping on someone. But as nurses today, we need to learn how to delegate, because I've said it 100 times, we can't do everything for the patient. So we have to delegate some of the chores and tasks, and even some of the care that needs to be given to our patients on other people that we work with. So let's look at some of the aspects and important information concerning delegation. What is delegation? It's a transference of responsibility authority to competent individuals, and the delegate will assume responsibility. That's the person that receives the task or the job to do, and the delegator assigns the task, but still retains accountability. The delegator can devote time to other tasks, and with the person who's receiving the delegated task, it can help them increase their skills and also abilities of the delegate too. It's a very difficult leadership skill. There is some confusion over who is allowed to do which task. So as registered nurses, we need to know who can do what before we actually delegate that job to another person. It's a critical skill for nurses just to find that balance between not giving too much responsibility to somebody else and under-delegating, okay? And we can accomplish more and provide better care for our patients by using others' help. So what are the principles of delegation? RNs increasingly delegate components to other RNs, LPNs, to nurse extenders. We call those UAPs, PCNAs, STNAs, home health aides, client care technician, orderlies, and surgical techs. These are the things that can be delegated. Vital signs, measuring INO, client transfers, ambulation, postmortem care. Yes, they can help after someone has passed away. They can help with the care of that body, bathing, feeding. With feeding, you want to make sure that the patients are in proper positions, that it's a safe environment, that the person that you're delegating that job to will remain and keep that patient safe without any problems with aspiration or choking or things like that. Gastrostomy feedings could be possibly a job for someone other than the registered nurse, but you really need to know hospital policies. I'm not sure if I totally agree with that. Tasks that can be continued again are attending to safety, weighing, performing simple dressing changes, suctioning. I'm not sure I would allow someone to suction a chronic tracheostomy. Performing basic life support, but they should know CPR. Tasks that cannot be delegated are a assessment, interpreting data, making a nursing diagnosis, creating a nursing care plan, evaluating care effectiveness. And that makes sense. It's all part of that assessment process. They don't have the skills and the knowledge to be able to do that because it requires thinking, critical thinking, and they don't have the education in the background to do that. Other tasks that cannot be delegated of care of the invasive lines, and I don't care how busy a nurse is, none of these should ever be delegated to someone who's not a registered nurse. It's not in their scope of practice. Administering parenteral medications, inserting NG tubes. They should not teach patients about anything, performing triage, giving telephone advice. The principles of delegation: delegate to a UAP. Nurses must assess first and then determine when that delegation should occur. Patients that are medically stable, or even a patient that has a chronic problem, the task must be considered routine for this client, not require substantial scientific knowledge or technical skills, be considered safe for the patient, and have predictable outcomes. In delegating to a UAP or a PCNA, the nurse must learn agency policies, know scope of practice, and be aware of variation in ability. And this is what we mean by that is you're going to determine, whether or not you're going to give a task to a UAP. If they're just getting out of orientation, you may not give a certain task to someone who just doesn't have that experience, as opposed to a UAP who's been doing this for 10 years. So that's what we mean by aware of the variation in the ability to perform that task. Maybe someone has passed away on your floor and the one PCNA never has really done more care or postpartum care, so maybe you might want to go in there with that PCNA and work with them and explain to them what the hospital policy is when we're doing postmortem care. Observe if unsure of abilities, clarifying reporting expectations, and to create a positive atmosphere. Delegating to unlicensed assistive personnel must understand for each patient or client task to be done, one task is to be done, an expected outcome, and who is available as a resource, when and in what format report expected, and a specific task. So if you want someone to do something, you're going to delegate a certain procedure, you do need to say, hey, I need a blood pressure taken and I'd like you to come back to me in 2 minutes and report that. I need to know that now because we've had some blood pressure problems and I've been giving medication, so I need to know that within 2 minutes after you take the blood pressure. Because if you don't give specific directions, that PCNA may go off and do other chores and not come back to you and give you the information that you need right at that point. So make sure you're very specific about what you want done and what is the expected response to you as the registered nurse. So the principles of delegation are different from assignment. Obviously, people that you work with will have their own specific assignment. This is beyond. Maybe you, you know, they took the morning blood pressure. They know they have to do that, but maybe there is a problem with the patient's blood pressure, and maybe they need to now be on blood pressures every 2 or 4 hours. So you are going to say, I need you to take a blood pressure every couple hours because we've been having a patient with